Dear Andreas Jordan, you are Executive Vice President and Managing Director, Europe, Founder and Chief of Scientific Officer. All that what you are is remarkable. You are since 30 years in research and development and clinical development. You have regulatory approval for your product, and you have new ideas and strategies all the time. It started at Charité, where you made a spin-off and founded Markforce. And today you are on the stock of Frankfurt, on the stock exchange, and what is in between, as I know, since you were with us also 2009, is a huge struggle with falling back and going forth and going forth. And I always have admired how you have done this during the years when I followed you and saw how you are doing this. So your topic now is fighting the tumor from the inside. It is this system, Nanotherm, a therapy system that was the first device ever receiving European approval for iron cancer particles. I think we are looking forward to hear this story and the development from you now. Please, the chair, now it's your talk.
Yeah. Hello, Beat. Thank you so much for your really, really nice introduction. And we know each other so long, so I also appreciate. I am honoring you about this Nano Cleanup all the years, and I know what this organization is. For earlier times, I was doing my own Nano conference, Nanomedicine conference. So it's really incredible what you and Patrick are doing, has done all the years before. So thank you very much for this invitation, and thank you very much for the opportunity to give you an update about what has happened in the meantime, the years before, about Markforce and its technology. So first of all, I would like to come to present our Nanotherm therapy system. So first of all, we are talking about thermotherapy. And thermotherapy, it's well known over decades that there are combinational effects between chemotherapy and radiation therapy, and that thermotherapy is alone also effective, called thermoablation. So the molecular mechanisms, how really chemotherapy and certain drugs are made more effective in combination with thermotherapy, as well as radiation, is all well known. It's described in lots of review papers and confirmed by clinical studies as well in different organs and different cancers. The problem was more that giving this knowledge, we need devices which are able really to target the heat sink dust to the tumor tissue and sparing normal tissue, because otherwise normal cells are equal. That's most people are wrong with it. You know, the tissue, normal tissue, is equal sensitive to heat than cancer tissue. But secondary effects, which I will show you a little bit later, some physiological effects, in fact, make the cancer cells more susceptible to heating. So especially the problem with brain tumors was very, very challenging at that time already. But people were trying to get some local therapies into the brain tumor using different strategies. And this is a picture I took from a very new publication in Nature Reviews Neurology, which shows that the local therapy has an enhanced value, which has been recognized over the years. So the local therapy has an impact in terms of patient survival with these most malignant brain tumors called Glioblastoma multiforme. For example, clinicians are using stereotactic injections. That's what we are doing using iron oxide nanoparticles. Also, radioactive iodine seeds are used, chemotherapeutics, and certainly CED, convection enhanced delivery, plays an important role. How to distribute certain chemotherapeutic agents, viral vectors, cytotoxins, and other liposomes in the target volume. Well, then what's an older discovery, older technology is implantation of reservoirs, also to give a high dose chemotherapy into the brain tumor and the intraarterial delivery. But I can tell you the intraarterial or intravascular application of these substances is really difficult with GBMs, because GBMs does in fact do not look like this drawing here, because the glioblastomas are not round shaped, not equally shaped. They are like finger shaped, so they are really deeply infiltrating into the tissue. So that makes them almost coming back. So in 90% of the glioblastomas in the first line therapy, we see recurrences because conventional resection, radiation, and chemotherapy are not effective as it needs to be. So in this paper, it's called magnetic hyperthermia, which is a more general expression for this, what MagForce has invented in terms of the Nanotherm therapy system, which is globally unique and is the only one which is regulatory approved with all its components in all 27 European countries. So what we can do with this, the potential has been shown from hyperthermia against glioblastoma very early already. So it was in 1998 where the group of Penny Sneed at the UCSF in San Francisco made a very interesting study in a randomized setting where they were using so-called antennas, radio frequency or microwave antennas, which are in principle wires which were implanted into the tumor surgically. And because of the thermal coverage requirement, lots of these antennas need to be implanted into the tumor tissue just to get the whole tumor really heated to at least 43 degrees or above. With this technique, lots of hours of neurosurgical interventions are required to bring up to 20 of these antennas into a bigger glioblastoma tumor. And so it arises not only the additional work, it's also the risk of infection, which arises and is a drawback. It's a hurdle to implement hyperthermia with these brain tumors. But this early study really showed in this randomized trial already that these people were able to double the 2-year survival of glioblastoma patients from 15% with radiation alone versus 31% radiation and hyperthermia. So it means that from this study, we can learn that hyperthermia really has the potential to enhance survival of these GBM patients. And in 2010, at which time we are conducting our clinical trial, which was later leading to our regulatory approval, we could in fact confirm the doubling of the life expectancy again with GBM recurrent patients. So what we received was, a median overall survival comparing 14.6 months just with radiation alone, compared to 23.2 months radiation just by the addition of hyperthermia, just the addition of heating. This survival time was doubled. So the potential is there. It has been shown by several studies. So what about the method, how to do it? Hyperthermia is not only killing cells. Hyperthermia is not only sensitizing cells against radiation and chemotherapeutic drugs. It's also doing a physiological effect, which is even more important when we are looking at tumors which are rapidly dividing, growing rapidly as it is with the GBMs. So in this case, when heating, the vascular structure of such a tumor, just because the neoangiogenesis is present there and the growing of the vessels has to be done very rapidly as a tumor is dividing and increasing rapidly in volume, these vessels are certainly imperfect. And this imperfection in the vascular structure makes them more sensitive to heat than normal tissue. Normal tissue can enhance 20 times, for example, our skin vasculature can increase 20 times the perfusion rate. But the tumor is able to increase just double, so 2 times the perfusion rate with this imperfect vascular structure. So if we are really maintaining the right temperature being more than 43 degrees, then these vessels can break down, they ablate, they are destroyed, which is a chain effect then on the efficacy of the therapy, because the perfusion is going down, and then more of the tumor tissue is destroyed just by continued heating. This is a physiological effect, which is really important to consider. So how to do it? You know, imagine I told you the work from Penny Sneed, you know, with these antennas, and every antenna needed to be implanted very precisely in a precise direction in the tumor tissue. And we needed to have access to the tumor in open surgery or stereotactically. It's a very delicate task. So the invention I did a long time ago facilitates the delivery of the heat largely through nanomedicine, through iron oxide nanoparticles. So that's the first component of the nanotherm therapy system, is the Nanotherm, which is a dispersion of iron oxide particles in water. The second one is a planning software. It's a post-application analysis, which uses the post-application CT scans for quantification and localization of the nanoparticle deposits. And from that, because we have a specific absorption rate for a given magnetic field strength applied, we know the specific absorption rate in advance. The patient is treated in the device. So we need already the energy term, the energy input, and using the bioheat transfer equation, we get an estimate of the temperature gradients in the target region and beyond, based on the energy absorption, which we know exactly using the particle concentration and localization in the target volume. Last but not least, we have a special device, which is called Nano Activator, which transmits the energy from this activator, the magnetic field energy, non-invasively to the patient into the nanoparticles, and then the nanoparticles are controlled, heated just by the increase of the magnetic field strength. During the particle implantation, also a closed-end thermometry catheter is implanted, which allows us in the whole course of heating just to measure the temperature directly during the therapy course. So we have control by this planning, by nanoplan. We know the thermal gradients in advance, what will happen. And secondly, we have proof that the temperatures which have been simulated here using mathematical equations are really present in the patient as well. So, so if we, let's have a closer look. The product, this Nanotherm, is regulatory approved since 2010 already. So since that time, we are working on market introduction, we are working on reimbursement and expansion, and bringing more devices to the European market. I come to this later as well. So have a look to, if we have a look to the Nanotherm, it is an iron oxide. It's a iron oxide magnetite with a median core size diameter of 12 nanometers, which have a thin coating of aminosilane. So the aminosilane has been specifically designed for this particle to build stable deposits. So there are more patents which MagForce has added the last 2 years just to increase the performance of these particles. So once they are injected into a tissue interstitially, into an existing tumor, or I will show you immobilized at the resection cavity wall, then these particles absorb heat and they are building stable deposits, which is really important to have a previous calculation of the heat and thermal gradients in the target site, and also to make sure that the thermal coverage of the whole tumor is maintained. So, now we talk about the clinical application methods. We have two methods available. One is for resectable tumors. So in earlier stage, smaller tumors and not in eloquent areas, which can be surgically removed. In this case, the nanotherm, the nanoparticles, are impregnated into a cellulose matrix, which is used normally to stop intracranial bleeding. And these matrices, where with the impregnated particles, are placed alongside the surface, the inner surface of the resection cavity. We know, and that's just described in this Nature Reviews article as well very nicely, more than 80% of the recurrences of GBM arise from the resection cavity wall and nowhere else. So this is a source of recurrent tumor growth. And exactly there, we are placing these matrices with the particles just to heat inside into the environment of the resection cavity, where the neurosurgeon was not able to resect more of the tissue to avoid that patients will have some damage in normal tissue in certain centers, motoric or speech center or whatever. So what hyperthermia can do, and it's combined with radiation and or chemotherapy, but with small tumors also, we can do thermal ablation just by increasing the magnetic field strength. Also temperatures between 50, 60 degrees and even more can be applied. However, if you are doing thermal ablation, like the other technology, laser-induced thermotherapy, which exists also a long time already, then this direct thermal ablation induces edema in the tissue, in the brain. And when the edema is really increasing rapidly, then a pressure, an intracranial pressure will occur, which might be a life-threatening event. And then you need to use a medication or as a neurosurgical intervention to control this edema. The edema itself arises with other therapies as well, but we need to control it. Edema means that there is an effectivity, so that tumor cells are dying, so that we are doing really an effective therapy. But just to avoid any complications with the patient, we have to carefully control this edema. And that's exactly what we are doing with this therapy as well. So here is just that you have a practical imagination how it looks like. This is an open OR picture showing, the cellulose matrix impregnated with the particles. So we are doing it like a sandwich. So, the resection cavity is covered with these cellulose matrix and the particles. And this is the first layer. And then we put in longitudinal, we are putting in this closed end thermometry catheter so that we are able to measure the temperature during the activation. And then a second layer is put on top of the catheter so that the catheter is really like a sandwich between two layers of nanotherm, two layers of the heating. So once the particles have been placed onto the resection cavity wall, then in picture B, we have a typical post-application CT scan. And as you can see here, I don't know whether you can see my cursor here, but you see here the white spots, the white spots here. This is all the nanotherm. These are the iron oxide particle deposits, which will give us then the heating. And in the post-application PET CT scan, we can see then remaining physiological activities. Nowadays, we are using even PET CT for planning of placing the particle deposits just to target the sites of the highest physiological activity. And we use this PET CT also for follow-up of the patients. So here's another image which shows a patient example. So initially the patient was coming with this third recurrency already. You may see here the resection cavity, which is a result of former resections already. And then apart from this, as I said, apart at the resection cavity wall, further two foci of actively growing tumors were located using PET CT. So the neurosurgeon was putting the nanotherm into these foci, and also for safety, he was putting, NanoPaste, so this matrix-bound nanoparticles into the resection cavity as well. And as you can see, that's the picture after 3 weeks. Here you see the particles still are located here. This is the gray matter here, but you don't see any physiological activity anymore in PET-CT, so the tumor has been controlled. It was a patient from the Dominican Republic in this case, and he survived 3 years, although with a third recurrency, we expected without the therapy, not more than 3 or 4 months. So this is some examples. So when the tumor is not resectable, we can help the patient as well. Just by so-called reverse biopsy, we are infiltrating with a special methodology the particles into the existing tumor. So this is done by conventional interstitial application, as I said, reverse biopsy, using conventional stereotactic devices or devices of neuronavigation. So the particles are targeted at several target points in the tumor. And then again, nanoplan helps us to see whether the thermal coverage will be obtained at a certain magnetic field strength. So the neurosurgeon knows exactly in advance what magnetic field has to be put in, and certainly a thermometry catheter is also placed into the tumor. So we have full control on the temperature there as well. This is again a picture out of the OR. So here you see this is stereotactic place in this example. And here you see the syringe with the nanoparticles combined with a stereotactic ring. Nowadays, mostly neuronavigation is used instead of stereotactic ring because it's from the practical point of view, it's a little bit easier to apply. But we need certain number of deposits which are required really to heat up the whole tumor. The interstitial application has to be done with a microliter infusion pump or stepwise, just to avoid any volume effects, so that the particles, the dispersion has time that water can dissipate into the tissue without damaging the tissue, and then the particles have time to build the nanotherm deposit, which is a small mass really. So 80–90% of the dispersion is water. So we can avoid really any volume effect during interstitial application just by using certain methods to be applied. So here again, a typical example. On the left side, we see the planning MRI with the progression of the tumor into the former resection cavity. So it means, the cavity, the tumor has been resected, but very rapidly a recurrent tumor growth has filled up the resection cavity again with new tumor. Particles were applied, and in the CT scan in the middle, you see again the white spots, and the white spots are really used with nanoplan to quantify the particle amount and localization. And from that, and that's the right picture, it's a typical result of nanoplan. It shows then through in this resolution of the CT scan. So if you have 2 millimeter slices, you have a resolution, certainly of the temperature gradients as well in 2 millimeter resolution. You can see through the target volume what temperatures to expect for a certain magnetic field strength. So it is shown here as isotherms or thermal washout. You can choose for different pictures, but you see then a certain color here is coding then for a certain temperature. So in the next slide, there's another picture which shows a limitation of the method. In the picture A, you can see a typical MR artifact, which arises if you are investigating the patient after the iron oxide nanoparticles have been applied. Certainly, the magnetic particles disturb the B0 field, so the local information is lost, which means that the patients has to be follow-up investigated using PET-CT. But the use of MRI is not dangerous to the patient. So we have patients who are, in fact, investigated with MRI after iron oxide particle application, because the neurosurgeons would like to see whether there is another tumor on the contralateral side. So outside this susceptibility artifact, the anatomical information is still intact. So you can MRI, you can use, the particles are not heated in MRI. So there is no, and they are not dislocated by the B0 field of the MRI. So there is no danger to the patient. So, but for the follow-up to see really the target region, we have to use PET-CT in contrast to MRI. So that has to be considered. So when we look to the workflow, so we have a conventional resection of this glioma. So the neurosurgeons are really loving this method because it's not, in contrast to the earlier work from Sneed et al., what I told you before, it's really easy going, because once they are doing the resection, just to do the impregnation of the particles into the cellulose matrix, that's easy going, as they are using the same matrix just for stop bleeding during the resection. So they have this material on hand all the time. So they are just putting this to the resection cavity and then closing the skull and the dura as it is normal. So it's an additional effort from about 15 or 20 minutes of a several hours resection. That's really important, that it matches nicely to the workflow of the normal resection of the GBM patient. So then the PET-CT has been done, will be done after application of the particles. Why? Because we always in PET scan, we have no absolute values of the PET activity. So we need a base value of the SUV, the standard uptake value, to have a comparison then whether there is an enhancement later after the therapy or not, which will be then the indicator for recurrent tumor growth. So after the PET-CT has been done, then we go into nanoplan. We are looking for the thermal gradients. There is some recommendation of the magnetic field with what the patient will need. And then the patient is put into the Nano Activator for 1 hour. And this treatment is repeated 2 times a week, altogether 6 times 60 minutes. Why so many times? Well, this has really serious biological reasons, because the thermal dose is defined as being the temperature over time. Very often I hear only that people are talking about temperature with hyperthermia. Temperature is nothing without the correlation of the treatment time. This gives us a thermal dose, and the thermal dose is correlated in the clear correlationship between death of cancer cells. So once, for example, we have at certain regions in the tumor only 41 degrees or 42 degrees, we can compensate this low temperature by the multiplication of the activation, by the multiplication of time, just to compile to enhance the overall thermal dose by the 6 times activation. So it means that even areas which are reaching not a very high temperature, 43 degrees or even 45 degrees, cancer cells will be destroyed because we repeat this treatment. And why 2 times a week? The interval is always 48 hours, because we know that cancer cells and normal cells as well are able to build a resistance against heating, which we call the heat shock or chaperone response. So once you would treat the second time directly after the first time, the cancer cells would be much more resistant to the same thermal dose. But we know also from lots of biological preclinical investigations, we know that after 48 hours, this chaperone response goes back to 0, just for energetic reasons, because lots of proteins are synthesized. That's a lot of efforts and energy, which the cells are really cannot maintain over a longer time. So the chaperone response goes down after 48 hours. So once we are treating the patient first time, for example, on Monday, the second time is on Thursday. After the chaperone response is down to 0 again. So the cancer cells will be sensitive as it was for the first activation. That's why we are doing 2 times a week. And now you understand why we are repeating this treatment even 6 times for 60 minutes. Yeah, then the follow-up, as I said, is done with PET-CT imaging 3, 6, and 12 months after the therapy. And so we have complete control, and we are able to detect any recurrent tumor growth early enough. So just a few words about the nanoplan, what nanoplan is doing. Nanoplan is able to fuse informations from all sources available in the clinic with every patient. So data from CT, MRI, from PET scan, so that the segmentation of the target region, so the tumor and adjacent areas, are based on all the informations available to make sure that the clinical target volume, the CTV, is really matching the thermal coverage of our heating. That's really important, because if we spare certain areas around the tumor and will not heat them enough, then this will be a source of recurrent tumor growth again. And that's exactly what we want to avoid, that this patient again and again receives recurrent tumor growth. So that's a little bit just as an illustration. This is a bioheat transfer equation. In this case, it's a TENS bioheat transfer equation, which does the calculation from the energy term, which we get by the SIR of the particles for a given magnetic field, to the temperature gradient. So it's a straightforward process that we get then from a straightforward workflow, importing data, doing the image fusion, doing segmentation of the regions. So we tell the software what is tumor, what are the particles, what are surrounding regions, and so on. And also the catheter is segmented, so we can make a nice correlation between the temperature measured along the axis of the catheter and the simulated temperatures, which is again a verification that we know exactly the thermal dose in the target tumor. And then at the end, we get a report, and this report is a part of the patient file. So it's all reproducible, what has been done with the patient. It's all well documented, what temperatures arise at a given magnetic field strength. So that's how it looks like. So based on the resolution of the CT scan, you can see all the temperature distributions in all axes, axial, sagittal, coronal, whatever the neurosurgeon wants to see. And this gives a whole picture of what happens in the patient. So I think I have six and a half minutes left. So, in the next development of NanoPlan version 4, we will have even a pre-planning tool, which gives us then the localization and the amount of fluid to be applied in a target volume, so that the neurosurgeon gets a guidance where to put the fluid in which amount, just to get this thermal coverage done in advance he's doing the application. In case of the combination of radiation, it's very easy going workflow. Again, we are doing just a 2 times weekly activation, combining with 5 times per week standard 2-gray treatment with external beam irradiation. And just here to see some results, these are some old results from our approval study. So I told you already there was a doubling of the survival time after detection of the recurrency of plus 7.2 months that we call the OS2. And also we have the OS1. It was a plus of 8.6 months of patient life. And this was incredible at this time, because none of the experimental studies were able, even with big tumors, as we had in the study, to show this benefit for the patients. So in the meantime, certainly more studies were done and more results were achieved. I'm just picking up 2 of them because I think they're really important. So what we see here is a study which was published in 2019. It has been shown that NTTS combined with radiation is a potent anti-tumor response, which is arising there, so a local inflammation reaction, which is leading to a long-term stabilization of GBM patient survival, because the cold tumor, so the immune system was not able to recognize these tumor cells during hyperthermia, and even months after end of the therapy, the immune system is still active against these tumor cells. So it means that over the local effect, what our heating is, also an effect over the whole brain is fighting against single cancer cells. And that's really something which goes in the direction of immune therapy, which means hyperthermia even can do a potential activation of the immune system, makes the tumor cells to hot cancer cells and will target them to fight against these cancer cells. A second paper was published this year, which describes exactly this edema topic. So how to control the edema, how to control side effects of the therapy. I can only say from the approval study said that less than 3% of symptoms which were arised new, where only 3% were new in comparison to what the patient had already before, because we were treating recurrent tumors. So they had already resection, radiation therapy, and chemotherapy. So mostly they come with neurological deficits, which we cannot get away, certainly. But we are not adding really more side effects than the patient had before already. And that's good because lots of other therapies, think about chemotherapy, especially certain drugs, we have really an addition of side effects. So finally, I want to give you just an overview about our ongoing studies. So just to have an observation, what happens in our commercially available therapy on the market, I established a European registry study. So all patients which are treated in the commercial setting, they are also part of clinical research. So in this European registry study, we have centers contributing in Germany, Poland. Now this year will be added in Spain, Italy, and Austria. So we have a big database which collects quality of life, which collects side effects and the outcome of the therapy in terms of survival. So these data will be published in a few years. So it means performance and safety again is observed. So every patient treated is also a benefit, a progress in terms of understanding more details about the effects of the therapy. Just to go into direction in new countries outside Germany, we need certainly also going forward in terms of reimbursement. And for this purpose, we are setting up in every country outside Germany, so Poland is very active already, RCT studies, so randomized clinical trials, where we are randomizing NTTS against standard of care. And we are putting together with using the same protocol in different countries, which means that we have a limited number of patients in each country. But once we are using the same statistical plan, we get a large number. So for example, 4 times 21 plus 21 patients gives a total of 168 patients, which gives us a great significance of the data we can draw from these studies finally. So this is about this country studies. And last but not least, if you have someone, I'm praying that you don't have anybody in your relation, in your family or wherever having or receiving the GBM diagnosis. But if you're a clinician, if you're here of someone who has a GBM, I really recommend that you're going on one of these 3 pages. We have neutral information on the diagnose-glioblastoma.de page in English and German about all options available for GBM, including NTTS. So that's a complete and comprehensive image where patients can get information, what is possible just to increase their lifespan, and that maybe the prognosis given to them, it's not really true, because lots of patients really survive this glioblastoma using our therapy, and no recurrency over many years was detected so far. So it is, we cannot get a guarantee. We had especially problem with this pandemic, because patients were coming far too late because they were anxious about infection of viruses in the clinic. So they were coming too late. And then when the tumor is too big or is, infiltrating eloquent areas already, then it's too late. If we can't do any surgical intervention to place the particles on the right spot, then we can't help even in this case. So please, to the patient, just clear message, come as early as possible, and then we can add an additional potential. So Alivia Cancer Foundation in Poland is supporting us a lot. And on the MacForce page, you will also find nice information and phone numbers in 10 languages where you can contact doctors using our therapy. So finally, I thank you very much for listening to my talk. And I am really eager to hear all the questions coming up now, certainly. Thank you so much. And thank you, Beat, for this wonderful introduction again.
You didn't hear me. Yes. Thank you very much for this beautiful talk. And when I look back in the proceedings of 2009, you had a perspective talk and you said, what are we going to achieve? And when now I look, I can say you did it all. It is probably your talk is so clear that now we don't have questions on the stream. So I propose we go to because there are far more than 100 people at this moment listening to you. So I think we should go to the Zoom room and we should there discuss and take questions. I'm sure many people will follow us now.